So, good evening everyone. Thanks for everyone who braved the literally foul weather outside to come, so well done. My name is Ralph Becker, I'm from the economics department. I'm not going to spend much time here, just a couple of organizational films. This talk is going to be filmed. There have been notices at the door. If you don't want to appear on any footage, then you need to make sure you sit in a back 2 rows. Also, toilets are here in the basement floor. So if you go out and go down the stairs, you can get to the toilets. And lastly, there are no plans for any fire alarms. So if an alarm goes off, then we follow the instructions and leave. So apart from that, all I'm left to do is to welcome Anita Charlesworth. She's the Director of Research and Economics at the Health Foundation. The Health Foundation is a research institution that does work into health policy aspects. Is also giving grants. So I don't know, some of you may be being paid by the money of the Health Foundation. So thanks for coming as well. And I asked Anita what the most exciting aspect of her career is she would like you to know. And she worked at the Treasury as a Director of Public Spending. That's a quite splendid job title, and even more splendid if you understand that this means she was the big credit card holder. Okay, so I'm not going to repeat what amounts she spends. Your eyes would be watering. Anyway, Anita is going to guide us through this evening and is going to introduce George Stoye from the IFS. You have your
Oh, yes, so I do. Excellent. Okay. So welcome, everybody. I should say, if we're going to talk about health care today, one of the things that, building on the introduction, that will characterise this is very large numbers. Yeah. So I think this evening should be a really interesting discussion, and I guess 2 bits of context for why this is a really interesting topic and a really good point to be talking about it now. So people probably very familiar with Benjamin Franklin's quote that there are only 2 certainties in life, death and taxes. And basically George, I think, is going to spend sort of 40 minutes or something talking a bit about why death and taxes are quite connected in thinking about health and social care. The other thing which is quite interesting is that we're going to talk quite a bit, obviously, about the economic issues associated with health and social care. But I think, and the economics of health and social care are really, really fascinating. They're great examples of why economics has so much to contribute to public policy. But the other thing that's really interesting maybe to think about as George is talking is that health and social care are a really interesting piece of applied economics, but also actually they are fundamentally important to who we are as individuals, and that point about death and taxes and how we see life. And they're incredibly important, and we are in the middle of the start of a general election campaign in terms of public concerns. So I was just looking at Ipsos Mori, the opinion polling company, do a monthly tracker of, they poll a sample of people of issues of concern. And unsurprisingly, Brexit is the main issue that people identify at the moment of concern. But the second issue, and consistently the second issue that people raise as an issue of concern is the NHS. And quite interestingly, when they then break that down by political party and affiliation, people's interests the nature of their interests may differ, but actually concerns about health and social care are very high up for people, whether they are a Conservative, a Liberal Democrat, or a Labour supporter. So we differ often about how we would tackle these issues, but the salience of these issues to people personally and in terms of our politics and our public discourse is unchanging, and even in these times that are dominated by Brexit, remain incredibly high. And we've just seen already over the last week, as the election campaign has geared up, that actually there's been an NHS flavour again to some of the debate about Brexit. So really interesting topic and really interesting time to be talking about it. And given that very significant political framing for the debate about health and social care and the importance of it to all of us individually, and so quite often also a very emotional debate, I think it's really brilliant that George Stoye from the IFS is going to be giving a presentation today. In my organisation, Health Foundation, we work a lot with IFS, and I've worked a lot with George. And IFS, I'm sure you're all very familiar, but the IFS are 50 years old this year, and were founded really to try to bring really good evidence and analysis to bear on some of these really big public policy choices and decisions that we have and around public spending. And they do consistently great work, I think, in looking at the depth of issues, but then also thinking about not just great research, but how is that relevant to the decisions and the choices that we make. And George, first-class economist, and hopefully for those of you who are also thinking about careers in economics, you'll also see what you can do with the discipline if you do it really well, like George. Okay, so I'm going to hand over to you. And just to say then, George is going to talk for up to 40 minutes, and then we'll have a discussion. So think of your points while he's talking.
Thanks, Anita. So hopefully everyone can hear me. Thank you, Anita, and thank you all for coming. It's a great pleasure to speak to you. So I'm going to talk to you today about health and social care. I want to make it very clear from the outset that although the title suggests who should pay for health and social care, I'm not going to give you a definitive answer to this. Instead, what I want to give you are some tools and some economic concepts that we would use to think about this debate and think about, well, why does the government intervene in some markets, why it doesn't intervene in others, and then you can use those tools when people are having this discussion. So the first person I want you to consider at the moment is Sally. Sally has a chronic illness, kidney disease, and that means that she's going to need treatment for this every week for the rest of her life. So what she really needs is something called dialysis, which is a treatment that she'll have 2 or 3 times a week. And if she was going to have to pay for this herself, this would cost a lot of money. So over a 10-year period, it costs about £1 million to provide dialysis treatment. Fortunately, though, for Sally, she lives in a place where someone will pay for those costs, so the NHS will provide healthcare for free for her. Now, I want you also to consider David. David has dementia, which again is a condition where he's going to require care for the rest of his life, probably progressing as the condition gets worse. And that again could cost a lot of money. So you've got to pay for someone to come in and help you with the activities that you can't do anymore. Now, strangely enough, David has many of the same problems that Sally does, in the sense that he's exposed to a lot of financial costs, but he actually bears a lot of the risk himself. So if he has assets, that's wealth, money to start with, or he has high income levels, he's going to have to pay for this out of his own pocket. So what I really want to think about is, well, why does David pay for care, but Sally doesn't? And I want to use that to think about, well, why does the government provide healthcare? Why does it get involved in this market at all? Why doesn't it treat social care in the same way, at least in all cases? And what might we do to change social care that would make it look a bit more like healthcare, or at least to provide it in a slightly different way? So those are really the concepts that I want to think about today, and that's what my talk is going to be based around. Before I tell you or think about why the government provides healthcare, I want to just show you that it actually provides quite a lot of healthcare. So what I'm showing you on this graph here is the percentage of our national income, so that's all of the income in the country added together. It's a measure of how rich the UK is. What percentage of that the government spends on providing healthcare. So in 1949, the year after the NHS was formed, we spent about 3.5% of national income, or GDP, on providing healthcare. That has gone up over time, so the amount that we've spent on healthcare has outstripped the growth in our economy. And that means that in the latest year, we're spending about 7.2% of national income on healthcare. So this is a lot of money. This is about £150 billion in today's terms, so lots and lots of money. But whilst it's a lot of money, we're going to start spending a lot more in future. So what I'm showing you now is the projections from the watchdog, the budgetary watchdog of the government, the Office for Budget Responsibility. And they suggest that if we wanted to meet all of the pressures that are on the health budget going forward, so that's things like the fact that the population are aging, people have diseases that are chronic that we can treat better than we used to in the past, and the fact that things like wages need to go up. If we wanted to meet all of these pressures, we'd essentially have to double what we're spending on healthcare over the next 50 years to be able to provide the same level of healthcare to people. So to put that in another term, that's like finding another £145 billion, or £2,150 to every person in the UK. So we spend lots on healthcare. This is obviously a big issue. We're likely to spend more in the future. Just to say, healthcare is probably it's actually the biggest item of spending that the government has. So if you think about all of the money it spends on providing public services, so education, defence, justice, that comes to about £560 billion in the last financial year. More than a quarter of that was on healthcare. So if I compare it to the next biggest slice of this pie, that's education, and you see that it's about 2/3 bigger than that. So healthcare, again, is a really big priority in this country. We're not actually the only country that spends money on health or that cares about health. And in fact, actually, we look distinctly average when we look at how much people spend on providing healthcare to people. So what I have here is the UK is here, and this is saying the total amount of money that's spent on buying healthcare in the UK, split between the darker bar, which is what I was showing you before, which is what the government pays for, and the lighter bar, which is what people privately pay for, so going to private hospitals, paying for insurance, etc. So what you can see is that altogether we spend about 10% of our national income on healthcare, and we're pretty much at the average for Western Europe. But if you look at some of the countries that you would usually compare us to, so somewhere like France or Germany, we actually spend considerably less. So we need to spend between 20 and 30 billion pounds extra this year if we wanted to reach the same levels that France or Germany spend. The US are a bit of a strange outlier. They do healthcare in a very different way. It doesn't always work very well. But it is also still worth noting that actually what the government spends on providing healthcare in the US is still more than what the UK spends in its entirety on the NHS. And that's as a proportion of their economy. So healthcare is a big issue everywhere. So really, why is it the governments get involved with this? Why is it that the government wants to provide healthcare? Why does it want to fund healthcare? And why doesn't it let people just kind of do it themselves? A slight health warning. It is a relatively complicated reason why they get involved. I'm not the only person who's noticed it. So in February 2017, Donald Trump told everyone, I have to tell you, it's an unbelievably complex subject. Nobody knew healthcare could be so complicated. Of course, we're lucky that actually people have realized that it's complicated before. And as a result, people have actually given this quite a lot of thought. So I want to give you a kind of a flavor of at least how economists think about this. So the main reason why the government wants to get involved with healthcare, and lots of other things, is that people dislike risk. And that's thinking about individuals we think of as typically what I'm going to call risk averse. And by that I mean they don't like uncertainty. So in the future, a whole range of things can happen. Some of those things can be bad and some of those things can be good. And even for the bad things, they can be pretty small probability of happening. But people don't like the fact that that might happen, and they want to seek protection against that. So examples of that include things like, will I get sick next year? So there might be quite a small chance that that happens, but say you get sick next year and there isn't the NHS, you would face quite large costs in going to hospital potentially. So you might actually want to pay a little bit of money now to avoid having to pay any of that money if the bad thing happens. And that's what we would think of as health insurance. There's other risks as well. So thinking about, will I have a job next year? So lots of you probably at university at the moment, you've got to consider, when I leave university, am I going to be able to get a job? If I don't, what would happen? And similarly, if you're already employed, there's a possibility you might lose your job. So again, you might want to kind of seek insurance against that. And then there's also other risks. So some of the things, something you might actually think of as a good thing is that you might live for a very long time, right? So you don't know exactly how long you're going to live for. And if you actually live to, say, 100 when you're only expected to live to 80, you might run out of money. So actually, one thing that people want insurance against there is just actually living for a very long time. So people get pensions, people buy what's known as an annuity, where they're going to trade some money now, and they're going to get guaranteed income for the rest of their lives. So in all of these cases, there are risks, and individuals might want to buy insurance against these risks. So that doesn't actually stop the bad event happening, but it mitigates the financial consequences of that. So governments can play a really important role in insuring people against these risks. And that's often what we would call as social insurance. So the National Health Service is actually one example of this. So this might be a bit of a different way of thinking about the NHS than people have in the past, but in some sense it's just a big insurance scheme. Okay, so people pay taxes to the government, which is like paying a premium to an insurance company. So you pay money to the government, and in return, the NHS is going to provide treatment for you if you're sick. So you're not going to have to pay for that treatment itself. And in that way, we're going to get people who have high incomes subsidising treatment for low-income people, and we're also going to get people who are typically healthier and people who are sicker also getting access to the same amount of treatment, even if they pay in the same amounts. And what this does is actually removes the threat of having very high costs, or what I'm going to call catastrophic costs, if you get ill. Of course, the NHS also does lots of other things that are good. So one of the main reasons we think that we have an NHS is to make sure that people who have low incomes or no money at all can still be able to buy healthcare. So you're not going to be discriminated against just because you don't have the right levels of income. But of course, we could still provide healthcare in a different way. We could give people money so that everyone has equal incomes, and we could say, well, you can go and buy health insurance instead. And we're going to talk about maybe why that doesn't work in the next slide. So this isn't just about health either. So there are other prominent examples that the government of social insurance that the government provides. So things like unemployment benefits. You're paying in taxes today. If you become unemployed, they will pay you a bit of income. Similarly, disability insurance. So if a bad event happens and you become disabled, the government will give you some financial compensation for that. Okay, so if insurance is really so good, why do governments need to provide it at all? If people really don't like this risk, why don't they just go and buy health insurance themselves? Now that's complicated for a number of reasons, but one thing I really want to focus on, and it's really, really important in this market, is the fact that people have different information. Private individuals have different levels of information about their own health or about their own situation than potential insurers would. That's going to be key because insurers are only going to want to come and provide insurance for people in a private market. So this isn't the government, this is a private company. They're only going to want to come into the market if they can at least break even. So they really want to make a profit, but say they just want to at least not make a loss. So the way that they would really try to do that is they want to charge people who are more likely to be sick in future more money. Because in that way they'll be able to cover what could happen. They're going to cover what I'm going to call expected costs. So what they expect to happen in the future. But of course, say Anita's really healthy and I'm unhealthy and someone wants to charge us different prices, I don't really want to, I want to pretend to be Anita essentially. There's no reason why I say I'm going to want to pay a higher price. So then you get to this problem where insurers don't really know who's who. And when that's the case, that basically leads to the market breaking down and a result that we're going to call, economists would call adverse selection. So I'm going to talk you through an example of that to try and make it a bit clearer. And to do that, I want to show you three people. So these people all might want to buy health insurance because they don't like risks. So we have Ashley, Ben, and Christine. Now, Ashley is the healthiest of these people, so they all have a risk of being ill next year. And if they become ill, they're going to need expensive hospital treatment. And no one likes this risk. But Ashley's a bit healthier than the others, and therefore she has a smaller risk of this occurring. Ben is somewhere in the middle, and Christine is much less healthy. So why does Ashley want health insurance? Okay, so I said before, she's quite healthy. However, there's still a risk that she's going to get sick and she's going to need expensive treatment next year. So just in my example, I'm going to say there's a 10% chance that she gets ill. And if she does get ill, she's going to have to go to hospital and pay £10,000 for her treatment. So she's in a situation where she's either going to pay nothing because she's healthy, or she's going to pay £10,000 because she's ill. And although this is a relatively small risk of this happening, she still doesn't like the fact that this may occur. So what she might want to do is buy insurance, and by that I mean she might want to pay a small amount of money that means that she would avoid the possibility of paying £10,000. Now, Christine is kind of in a similar situation in the sense that if she gets ill and she goes to hospital, she's going to have to pay £10,000 as well. But she's unhealthy, sure. She's less healthy than Ashley, and so she has a higher chance of needing to go to hospital in the first place. And that's, I'm going to say, 30%. And let's say, for argument's sake, that Ben's somewhere in the middle, and that's 20% instead. So her expected costs, so what she might end up paying out, or on average what she's going to end up paying out next year, is £3,000. Okay, so that's, she had a 70% chance of paying nothing, a 30% chance of paying £10,000. So again, she might be willing, she wants to pay some money to avoid going to hospital, to having to pay the money, sorry. But she's more likely to actually have to go to hospital in the first place. So she might be willing to pay a bit more money to avoid all of those costs. But ultimately, she still wants to pay less, right? So she still wants to look like Ashley and to pay £1,000 rather than, say, £3,000. So just to put some of those costs, I'm sorry about numbers if people don't like them, but just to try and demonstrate this. These people all have these expected costs. So Ashley, who has the smallest risk of going to hospital and paying £10,000, has an expected cost of £1,000, Ben of £2,000, and Christine of £3,000. Now, in a world where insurers could tell perfectly who is the healthiest and who's the least healthy, they're going to charge appropriate prices to each person. So say that they want to break even, so they're going to charge Ashley £1,000 because that's what the expected cost that it's going to cost for the insurer company to actually pay out. In order for the insurance company to cover Ashley, they're expecting to pay £1,000. So they have a 90% chance they pay nothing and a 10% chance they pay £10,000. For Ben, they expect to pay out £2,000, for Christine, £3,000. So they can offer these things. If these people think they're fair, they're all going to buy insurance, so they're all going to be covered by insurance companies. And the insurer's happy to do this because they're making a profit of zero, so they're breaking even. So this is a world where everyone knows who is who. But say Christine actually thinks, well, I can fool the insurance company, so now she knows more than everyone else. She's instead going to want to pay the £1,000 that was offered to Ashley. So what the insurance company might choose to do, if it doesn't know who's who, is to offer a price which everyone faces, so it's an even price for everyone, which on average is going to cover the costs of people's treatment. So in this case, the average expected cost is £2,000. So they're going to offer a price of £2,000 to every person. But the problem is now that Ashley probably doesn't want to buy that insurance. So Ashley's expected cost, or her risk of being ill, is sufficiently low that she's not going to want to pay this money to buy that insurance. So what she does is she doesn't buy it and she's dropping out of the market. And what this means is that the average cost of treatment is now actually going to be higher. So the insurer doesn't make any money from Ashley because she's left the market. Ben, they're going to break even on again, so they're making a zero profit. But for Christine, whose expected costs are £3,000, but she's only paying £2,000 out, they can expect to make a loss. So what this means is actually the insurance company doesn't want to provide insurance for this price. And what they might do instead is to offer a price that would break even just looking at Ben and Christine. So the average cost between Ben and Christine next year that's expected is going to be £2,500. So they offer this price. Ashley still doesn't want to buy the insurance because it's even more of a bad deal for her. But now Ben might not want to buy the insurance either because he thinks that, well, actually, it's not a good deal for me. And what that means is we're only left with Christine. So the insurer is going to end up losing money on this again, or it's expecting to lose money. And it's not going to want to provide insurance like that either. And what we end up with is a world where they're only going to offer insurance to Christine, and that's at £3,000 where they can break even. And it means that Ashley and Ben actually can't buy insurance even if they want to. Now this is just an example for 3 different people, but you could imagine scaling this up to a whole population where you have a whole load of people who look like Ashley, a whole load of people who look like Ben, and a whole load of people who look like Christine. And again, we're going to run into this problem. Because insurance companies can't tell who's who, they're not going to be able to set the right prices and therefore make it worthwhile being in the market. So for this reason, the government might want to step in and regulate that market in some way. So what can we actually do about it? Well, remember that this problem only really happens because insurers can't tell who's healthy and who isn't, and because those healthy people could choose not to buy insurance. So the whole problem really arises because someone like Ashley on this slide can say, actually, I'm not going to buy that insurance at all, and that pushes up the average cost. So we can address this by actually just making sure that everyone has to buy insurance or is given insurance by the government. And in that way, we know on average how risky or how sick people are going to be, and we know on average how much it's going to cost, and we can set appropriate prices. So the National Health Service actually does this in the UK. Okay, so the government insures everyone, and it funds the treatment through tax revenues. So people pay their taxes in, they all get coverage. And that means that healthier people subsidise care for sicker people. So Ashley and Christine might pay, if they earn the same amount of money, are going to pay the same amount of tax, but Christine is going to end up using more of the service than Ashley. And that also adds that if we think that healthier, and on average this is true, if healthier people are also richer people, it means that richer people are subsidising care for poorer people too. Now other countries do this in a different way. So every country faces this problem when they want to try and set up health insurance for people. We and some other countries use a centralised health system. Other places do it a bit differently. So for example, in France, there's a health insurance market, but they make it mandatory for everyone to buy health insurance. So everyone has to go and buy insurance and then prove that they're covered. And people who can't afford this are given subsidised insurance or are given cash transfers in order to buy this. So they get around this in a different way. But again, it's fine because everyone is forced to enter the market and people can't leave if they don't like the prices. The US tries to do this a little differently, so they don't make it mandatory to do it, but they now offer very strong tax incentives for you to purchase health insurance. Now the problem here is that some people still choose not to buy insurance, and this leads to the market breaking down in some places. So some of you may have heard of problems in certain parts of the US, even post-reforms that Barack Obama brought in, where essentially insurance companies don't actually want to provide insurance to people because the healthiest people don't want to buy insurance. And that's really just adverse selection in practice. So this is a really big issue, and governments think about this very carefully. So the UK provides healthcare through the NHS, but it does raise the question of, well, is that the problem sorted? Like, is full insurance always the way to go? Is that the best thing? And the problem is that actually needs to be weighed up with something else, and that is the fact that having insurance might change the behaviour of people who are insured. And ultimately, that could lead to increased use of healthcare and spiralling costs. And that is something that economists call moral hazard. And again, I'm just going to talk you through a couple of examples of why this is important. So insurance might change people's behavior before an event actually happens. So this is the case where people know they're insured against a bad event happening. So they know they're insured against being sick, for example. And as a result, they might undertake more risky behaviours or less preventative action in the first place, and therefore they become more likely to be sick. So an example of this is having a flu shot or a flu vaccine. So in the absence of insurance, people might like to pay for a small amount to get a vaccine, which would stop them from getting flu. So if you get flu, it's a relatively kind of low probability event, but you can end up being very sick and you might face very high costs of going to see the doctor. So in a world where you don't have insurance and you face all those costs, you might choose to pay the small amount of money to stop that happening. But actually in a world where you do have an insurance, so for example, if you have the NHS, you might just take the risk of getting sick because although it's not very pleasant, you're not facing any of those costs in future. And because you don't have the vaccine in the first place, you're more likely to actually get flu. A second second way that insurance might change people's behavior is that once the event has already occurred, people who are insured might change their behavior. So, and this is really key because insured people don't face the treatment costs that they're going to get. Okay, so as a result, they might use more or more expensive treatment than they would if they were paying for it themselves. So a really kind of good example of this is the choice of using a generic or a branded drug. So say you have a headache and you go to Boots and you want to buy some paracetamol. You'll be presented with kind of two broad choices. The first you can buy is what's known as a generic drug, and this is just buying paracetamol that comes in a plain packet. It's probably going to cost you something like 40p for a packet of this, and it does the job. But you could alternatively buy a branded drug. So again, this is paracetamol, but it will have a brand name attached. So the picture says Tylenol, but there's all kinds of brands that do this in the UK. And in return, you're going to buy actually essentially the same drug as a generic drug with some fancier packaging, and it costs a bit more money. So say it costs £3 or £4 instead. Now, if you're going to pay for that yourself, you would probably choose the cheaper drug because it's doing exactly the same thing and you're careful about what you're spending. But say the insurance company or the NHS is paying for that, you might not actually care which one you pick, right? So you might end up spending £4 for these drugs rather than 40p. And you can imagine that if everyone is not making these decisions, and so for every drug purchase you have this trade-off, then it means that costs can spiral. And this is, we worry about this here, but this is really the crux of the debate in the US, that they're really, really worried that when people get more insurance, it just means that costs spiral, and they're already pretty high in the US. So what can we actually do about moral hazard? What can we do about this overuse? So in the UK, we employ two different methods. The first is known as gatekeeping. So when you're first sick, or you generally would go to your GP or a general practitioner, and they will examine you, or they'll find out what's wrong with you. And they might be able to treat you in their practice, or they prescribe you a drug and you go to the pharmacy. However, if you need further treatment, they then refer you on to a hospital. Now, you can't go just to see the hospital consultant in the first place without actually seeing the GP first. And in that way, the GP is judging who actually needs that treatment, and it stops people going to hospital and using what ultimately ends up being more expensive treatment unnecessarily. So GPs are going to play a really important role in stopping overuse of healthcare. We also use regulation. So the government only funds treatment that they deem cost effective. And by that I mean for the amount of money that they spend on the treatment, they work out what the kind of monetary benefit of better health is, and then they weigh those up. And that's done by an organisation called NICE, or the National Institute for Clinical Excellence. So through these methods, we try to control overuse of care and what we're spending. Now, other countries rely much more on something called cost sharing. Now, this is the idea that the patients are going to pay some of the costs themselves. So they either pay a fixed fee for that treatment, which is known as a co-payment, or a proportion of the costs. So they're going to pay, say, 10% of their bill, whatever it is, and that would be known as co-insurance. Now, other places use it. The UK, we have very, very limited use of this. So a prescription charge is really a co-payment. You're paying a fixed amount to get access to a prescription. Of course, in the UK, not actually many people pay that. So if you have a chronic disease, if you're old, if you're low income, you don't pay for that yourself. And in fact, 90% of prescription charges are still paid for by the government here. So we have a pretty low use of co-payments anyway. But other countries, which actually have very similar health systems otherwise, so somewhere like Norway, for example, which we think of as quite an equitable place, and has a national health service, they actually have more of these things. So they, for example, will charge you a small fee if you're staying in a hospital overnight. But obviously, this is a really, really important trade-off, right? So it might be an important thing for reducing the overall use of healthcare, because people might think a little bit more about how much of it they're using. But ultimately, it's going to expose patients to the risk of treatment costs again. So if you end up in hospital for a long time, you might end up actually having to pay quite a lot of that bill. And of course, that was the whole point of getting insurance in the first place, was that you wouldn't be faced with that financial uncertainty. So I've covered quite a lot there, so I just want to take a sec to recap. Private information is causing problems with the health insurance market. That means that the government needs to intervene to address that problem and some other problems as well. And in the UK, we choose to do that through using the NHS. But at the same time, when governments decide how they're going to do this, they have to balance that against this risk of moral hazard and the concern that people are going to overuse healthcare, and ultimately this is going to cost a lot. So this is the decisions that people have to make when they think about providing healthcare. There's obviously really good reasons for the government to be involved, but there are also some cons. Now, everything I've spoken about so far is about healthcare, and I promised you to talk about social care. So now I want to think about, well, actually, kind of what are the similarities of what I've just said in healthcare and what we're going to see in social care. So like healthcare, the UK does actually spend quite a bit of money on social care, but obviously this is quite a bit less. So again, I'm showing you as a proportion of the national income in the country what the UK government has spent on providing social care since 1996. And that went up again in the 2000s, but unlike healthcare, which is flattened out, this has gone down quite considerably since 2010. What is social care? Well, it's non-medical services that support individuals with physical or learning difficulties that cause problems with carrying out everyday tasks. So those everyday tasks are going to include things like housework, washing themselves, dressing themselves, cooking themselves meals, and generally being immobile and being able to walk around the house. So you might need to pay someone to come and help you to do these things, so that can obviously be quite a large cost. And unlike healthcare, social care is both needs and means tested. So what that means is that if you apply to get social care, you have to prove that you have difficulties with at least 2 of these everyday tasks, with dressing, with cooking, etc. And then if you want to get the state to pay for it, you also have to have an income that's lower than a certain threshold every week, and also assets or wealth below a certain level as well. So if you have more than £23,000 in your bank account, you will end up paying for social care until you exhaust that amount of money. So this is only provided free to those with low assets and with low incomes. And obviously that's really very, very different to the NHS. So the NHS provides insurance against these costs to everyone, regardless of how much money they have in their bank account, and that's not true for social care. What is slightly different is that there is much more chance of providing care informally for social care. So social care can be provided either by people who are trained or by people like your family, your friends, or your neighbours. And in fact, the vast majority of care in the UK, and indeed the rest of the world, is provided by informal carers. But of course, that isn't kind of a free lunch. It might have a problem, it reduces their ability to work, it might impact on their health, on their well-being, and ultimately that's not a good thing. And the National Audit Office actually estimates that this really contributes to a huge amount of money as part of the economy. So if you were going to replace the annual cost of these informal carers, it would cost about £100 billion each year. So that's actually 5 times what the government currently spends on providing social care. So informal care happens a lot, and it's a way that people try and get around the lack of public provision in social care. So why is it different than healthcare? So I noticed before that David has dementia. He's going to have progressively rising costs as he has more difficulties with these tasks. And if he had a lot of money to start with, or even most people have more than £23,000 in assets by the time they're 65. What this means is that he's going to have to pay quite a large sum out of his pocket and potentially a lot of money. But Sally also faces lots of financial risk, but she doesn't because she lives here and it's covered by the NHS. So how different are they? Okay, so both David and Sally in a completely unconstrained world would face potentially high costs of care. They might want to buy insurance against that financial risk. But a similar problem is going to exist in both markets. So I've already told you in healthcare, if the healthiest people don't want to buy insurance and the sickest people do, it's going to be very difficult for a private company to provide insurance. The same is also true for social care. So take a person, for example, whose parents had dementia versus someone who doesn't, someone whose parents didn't. They'd be more likely, on average, to also need care as they get older. And they're the people who are going to want to be seeking out care instead. But of course, the insurance company isn't going to know that about them, and they won't know how to appropriately price that care. So in both cases, the private market for health and social care insurance is going to break down. Now, for Sally, the state will provide insurance through the NHS, but for David, that social care is both needs tested and means tested, and what it means is that he's exposed to to the risk of very high care costs, which is obviously very different than what we thought about in healthcare. And isn't that exactly what we want to avoid? Don't we want to provide insurance to these people to stop those risks? So we're ending up with a situation where two things that are essentially just different conditions are being treated in fundamentally different ways, and this seems a bit odd. So people have been talking for a long time about how we could change social care, and I want to talk you through a little of that history and then think about, well, what are the more common suggestions for reform. So in 1997, when Tony Blair became Prime Minister, he launched a Royal Commission looking at social care and how we could change the provision of it. Could we provide more state-funded care? And his rationale for this was he didn't want his children to be brought up in a country where the only way pensioners can get long-term care is by selling their home. So in 1998, he launched this commission, and it reported back shortly afterwards and suggested that we should have free personal care. So that's the help with all of these tasks. Eventually thinking about moving to a world where we could provide free care in its entirety. Now, of course, more than 20 years on, we don't actually have that system. And in fact, Boris Johnson, when he became Prime Minister recently, said that this is one of the big issues that he wants to think about. So he pledged to fix the crisis in social care once and for all, and that he has a clear plan to give every older person the dignity and security they deserve. So it's obviously a big issue. Slight problem is that we don't actually know what that clear plan is yet. And there's been this green paper that we've been waiting for 2 or 3 years from the Department of Health to talk about exactly what they're going to do here. So we don't know exactly what that plan is yet. He may talk about it during the election campaign, and maybe we'll learn a bit more what that is. But here are sort of these are two types of reforms that people have suggested recently. So one suggestion is what's known as a cap system. So the main concern with the current system really is that people have a very large exposure to extreme care costs. So they might end up paying a lot out of their own pocket. So one solution would be just to say people can't spend over a certain amount in providing care. So if you go over the limit, the state would end up paying for the rest of it. So you're going to contribute a bit towards your care, and then the government will step in and pay for the rest of it. So the Dilnot Commission, which was one of these follow-on commissions that happened after 1998, so this one in 2011, recommended that there should be a lifetime cap of between £25,000 and £50,000. So the idea there is that if you pay £50,000 over a number of years to pay for social care, you then don't have to pay any more. Notably, the cap refers to personal care, so that's the payments that are actually made to people coming in to help you with the cleaning, with washing, etc. They're not paid, they're not covering rent or food costs, which are obviously quite large if you live in a residential care home. But it did make the system also a lot more generous. So at the moment, if you have above £23,500, you're meant to pay out of pocket, but this is going to increase means-tested help threshold to £100,000. So if you had less than £100,000 in assets, you wouldn't be paying for this. Now, this was actually legislated for in 2014. So in Parliament, they thought this was a good idea, but it never actually got enacted. So it hasn't become policy. And in fact, in 2017, the Conservative Manifesto promised something that was very similar to this, albeit with a higher lifetime cap, so more like 75,000. And that was very unpopular. So it was immediately labelled a dementia tax, and a lot of people got very angry about it. So not looking at the rolls, but if you look at the bottom, there were lots of headlines that kind of looked like this. So that sort of reform has not been very popular, but it is kind of one option, and it does get at least some way at looking at these, at stopping these catastrophic risks. A second suggestion has been free personal care. So that's the idea that the government would pay for all of the care that someone receives in terms of they would pay for the cost of someone to come and help you. Again, they're not covering the residential care costs. So this is actually the proposal that Labour have put forward in their, they've said in their recent conference. We think it's what's going to also appear in their manifesto. And that would provide free state-provided help with activities of daily living, regardless of where you live. This is in brackets in England at the top, because this is actually what's already in place in Scotland. So that commission that was launched in 1998 by Tony Blair, their suggestion was that we should have free personal care. That was actually taken up in Scotland, but wasn't taken up in the rest of the UK because of a lack of costings. So this system's been in place for a while in Scotland. And so this would just represent a rollout to the rest of the country, although there may be different generosity in who receives it or exactly what they're providing. Of course, there are some slight downsides to this, that there are big costs associated with both the cap policy and the free personal care. And this has put some people off. So recent estimates by the King's Fund and the Health Foundation, I think Anita is an author on this, suggested that by 2030 we need to find an additional £12 billion if you wanted to fund the cap system, or £14 billion if you wanted to pay for free personal care. So that's somewhere between half and 1 percentage point of national income. So that's basically like a 50% increase on that graph that I was showing you before. So clearly that sounds like quite a lot of money, and it is something that we need to think about carefully, but obviously it's a system that people should care about and think very carefully about how we might change it. The last thing I want to do, and I'm sorry to leave you on quite a down note, but I want to say that actually, again, that money in the context of the larger demographic challenges that we're facing is actually relatively small. Okay, so funding challenges already exist. So if I take the line that I showed at the beginning of the talk and I said, this is what the projections look like if we wanted to meet all the pressures on health. So this is what the OBR think that we might have to spend on health by 2067, 68. And they're suggesting that's going to go up from about 7% of GDP today to just under 14% in the future. Now I can do the same exercise for long-term care. So even if we don't reform the system, just because there's going to be more older people, therefore more people are going to be eligible for care, we're going to have to increase, or if we want to meet these pressures, we'd have to increase spending from about 1% of national income today to 2% over a 50-year period. And because I'm talking about demographic changes, I'm talking about older people using this stuff, I also want to show you what pensions look like. So pensions is we expected to basically find £40 billion in today's term if we didn't want to reform the pension system. So if we want to meet the pensions challenge, that's what it's going to look like. So between these things, we're suggesting that we need to find something like 10% of national income, which is a huge amount of money. It's about £200 billion in today's terms. Now, if we want to do that without raising taxes and without spending more, if we wanted to spend what we do now on services as a whole, if we didn't want to change the size of the pie that I showed earlier, we'd actually have to cut in half everything else that we spend money on. Okay? So this line here is just showing you what would happen to other spending by the government on public services if we didn't want to change the overall level of service spending. Okay? So if we want to meet all of these pressures, we're going to have to do something very dramatic to everything else. So we're already facing like huge demographic challenges and a really big debate about how we fund that. Now, if you wanted to spend more on everything else, you're going to have to find revenue from somewhere else. So you're either going to have to change the way that we fund these systems, which people don't really like talking about, or we're going to have to raise taxes to do that. So we're already facing a big challenge, and it seems sensible to think about how we provide this stuff whilst we're also thinking about how we fund it. So some key things to remember. Individuals and governments don't like risk, but the private market for insurance is often going to fail. So economists think that this is a really key issue as to why the government might want to step in and provide healthcare and all kinds of other things. This adverse selection, this who chooses to get health insurance, is going to be really important, but just providing insurance for everyone does come at a cost because we're slightly worried that people might overuse it. Health and social care are currently treated quite differently, despite the fact that they're very similar in the concepts and the risks. But attempts to reform social care have proven pretty unpopular over the last few years, or at least indeed over the last 20 years. And regardless of the systems that we actually choose to implement, there are big challenges ahead in how we raise the funding to provide this care, and also all the other things that the government does. So we need to have a full and frank debate about how we raise that money and the best way to provide this care now, because it's not a problem that's going away. Thank you.
Okay. Thank you very much. I'm just going to offer a couple of reflections for people to maybe to have a little bit of a think about as they're thinking about questions. So two things maybe to put in context a little bit more what George was talking about, thinking about not just the US and Western Europe, but how this is playing out across the world as a whole. So back in 2015, United Nations, all countries in the world signed up to the Sustainable Development Goals. And one of the Sustainable Development Goals, actually a suite of those, was to deliver universal healthcare coverage across the globe. Earlier this year I was in China, which is obviously a really big player in the issue about universal healthcare coverage, because they've got a population of over a billion. And they committed 10 years ago to try to move to universal healthcare coverage. Now, in 2000, a third of China's population had access to health insurance, and now 97% do. So they've increased coverage. You know, that is, what is that? Probably about, that's over 500 million people in a decade now have some form of healthcare coverage. But when we think about this universal coverage, and they're motivated obviously by the same thinking here, there are a couple of things that I think it's worth thinking about there. One of that is countries like China are often doing this partly because they understand the market failure question and that this is a role of the state, partly because they see this as a source of significant unrest if they don't meet demand for healthcare. But also in countries like China, they're worried about people saving. So they're worried about some of the macroeconomic dimension to this and the wider micro incentives and the impact on things like the labour market. That if people are really worried about risk of this degree, they're over-saving. And actually, when health insurance first came in Europe, it came in, I guess, first in Germany, really, through Bismarck's reforms in the 1880s. And that grew out of the experience of German industry and the craft guilds wanting to provide some coverage on a productivity argument. I mean, it was not actually a compassion for a population or an understanding of an insurance market failure, but it was a feeling that, you know, in order to ensure the productivity of your work, because you need to insure. But the debate in China, and the debate in many other countries are doing this, and some of the debate then around our affordability, is there are three different dimensions of coverage, really. So one dimension is how many people get access to some kind of healthcare insurance, yeah, whether it's tax provided or more classically provided. We have broadly 100% coverage. Everyone gets covered. China's now at 97%. But then there are two questions, and George talked through one. How much of that cost is covered? Yeah. So do I have to co-pay? Yeah. And is it right that it's completely free, or should I pay a proportion of that cost? The second thing is which health needs are covered, because actually there's no objective and time invariant measure of a healthcare need. Yeah. So we have doubled our healthcare spending as a share of GDP since 1948, when the NHS was founded, not primarily because we've increased the proportion of the population that are covered, or that we fundamentally shifted the amount of copay. There's been a bit of change there with, you know, prescriptions, charges, and eye tests and all of that. But it's fundamentally because what the health service does now, if you have diabetes or whatever, is unrecognisable from what their health service did in 1948 and was able to do in 1948. And what we expect in terms of health needs is changing. So 20, 30 years ago, Well, it's still the case now. You know, if you have cancer, broadly speaking, everyone will get treatment for cancer. If you have a mental health condition, for which there is an effective treatment, only 4 in 10 people get access to care. Yeah? Now, we rightly, and in this election campaign, I think several of the political parties will make a lot of commitments around mental health. But the cost of moving from 4 in 10 people getting any help to, let's say, 7 or 8 in 10 is a big step up in the cost. So a lot of the debate going forward and a lot of what drives the OBR's projection that will rise ever further is this question which actually there isn't a settled answer to. What are the nature of the healthcare needs that we should all have access to? And that will be a really big issue in all countries going forward, economically elsewhere. And so the first thing I wanted to ask you then, George, is, I mean, the numbers are huge, and the US are currently, at 17%, and they do some of these projections, and they get, they get up to broadly everything that America does is healthcare. So, and sometimes people look at that and they say, so it's unaffordable, yeah? And we just, we need to actually reform this much more fundamentally and recognise it's unaffordable. Does that make any sense economically as an argument?
I mean, so from an economic point of view, we think of, as we get richer, we want to afford, we basically would like to spend more of the share of our income on health. So it's what we call a normal good. So there's certainly, we would expect, I mean, a lot of the changes that we've seen over the last 50 years have been because fundamentally people want better healthcare and therefore are willing to pay it as they get richer. I mean, I think there is a concern, there is obviously a big concern that the share of this is always going to go up. Part of that is then going to be a policy choice. But then we could also think about, well, how do we actually just raise more money? So we have funded a lot of these increases over the last 50 years by essentially cutting spending on other things. So if you compare, say, health and defence spending over the last 50 years, health as a share of that has gone up, and defence has gone down by basically the same amount. So in some ways you might think we're just transferring money from defence to health. Obviously the world has changed. And since 2010, we've really accelerated all the cuts to other departments, whereas healthcare has been protected. So there's kind of a question about, is that really sustainable going forward? Like, what else is there left to cut? Do we want to move to this world where we're just spending on health? But we could alternatively, if we raise taxes, for example, we'd have more money to spend on these things to begin with, and then you could think about how you allocate that so you wouldn't have to cut the other places.
Cool. Okay. Yeah, so I'm going to take the 3, so 1, 2, 3, and then get George to respond. And I'll do that in series of 3s, yeah. Could you wait for the microphone just because I think they're recording it, and so they'd like to hear your question as well.
Hi. I've been reading about this recently, and I'm wondering about Germany and France and how you feel about this, because I've been reading about in Western Europe how individuals are prepared to contribute more to healthcare, and as such, because they're prepared to contribute more to healthcare, they value healthcare more in the sense that they actually appreciate that they're paying for it, so they ought to look after themselves, so they pay less, and so on and so forth. And isn't it the case that with the NHS, because it's just slided into our tax and often cuts are made elsewhere and so on and so forth, that sometimes we're very blasé and complacent about healthcare, where if we actually, because eventually we're all going to have to contribute more, it's just how we do it, and it's probably going to be through some sort of insurance, even if it's on your house, on social care or whatever. So isn't it the case that if there's some sort of compulsory insurance and the unemployed are covered, or the poor are covered in full, that we might actually realise the cost of healthcare and social care and therefore be less complacent about it? I mean, I'm really looking at the Western European systems.
Do you want to, if we take all 3, that might be, yeah, there's a lady there, and then there was a gentleman, yeah, 1, 2, 3, 4th row from the back, and then, yeah, we'll do those 4.
Hi, I just wanted to ask about like the third-party private services that the NHS like refer out to a lot now, and whether some of the costs could maybe just be recouped from keeping it within the NHS and keeping the money in there.
And so one up there and one there, and then we'll do those 4. Yeah.
Try to remember everything.
You've talked about health as though it were a consumer commodity, but actually you can't buy health. All you can buy is treatment, and treatment in itself isn't usually very attractive. You know, people don't particularly want to have bits of themselves cut off. And you also seem to assume that people knew a lot about their health. Your examples gave the impression that these people knew the healthcare costs that they would meet in the future. Well, most people don't, do they?
Do you have any suggestions for how we could finance health and social care equitably, accounting for kind of intergenerational issues?
Okay, lots of things to think about there.
Yeah, we might be here for a while. Yeah.
I'll probably take them in reverse order if that's okay. I mean, thinking about how do you fund these things? I mean, essentially, probably you could fund this in multiple ways, and they obviously all have trade-offs about those things. So you could just use general taxation, which over your lifetime you would have thought should balance out across those generations. Obviously, people who've paid lower levels of tax for the rest of their life are going to win versus people who haven't, but there's always kind of winners and losers in this. And then you kind of getting into a situation where, so we raise about 2/3 of all tax revenues from free taxes, from income tax, from VAT, from national insurance. Raising those things, it's hard to see how you could raise significant sums of money without raising one of those taxes. They have pros and cons. So VAT is less progressive than the other ones. Income tax is the most progressive. National insurance contribution is actually where you could probably raise the most money if you put sort of a 1 penny change on it. But older people, for example, don't pay national insurance. You don't pay that over the age of 65. So one potential reform which actually might get at that a little bit is to just make everyone pay national insurance on all income. So if you paid national insurance on earnings above 65, for example, you could raise some money. Maybe that would be a bit fairer. In terms of health as a commodity, so I guess what I'm trying to say most of the time is I'm thinking about the risks that are associated with it. So no one wants to be in bad health, and I agree that it's very hard to kind of value health. The idea of insurance there is to cover the financial implications of those things. And therefore, I do have to think, obviously the treatment's not completely reversing those things, but what you want the insurance against is the financial cost and being in a situation where you're not going to be able to afford those things. I agree that there's, health obviously it also impacts on your well-being. It's not just finances and things like that. So there's fundamental reasons as to why people should value it as well. And therefore, people should also think about, preventative healthcare. We should think about wider socio-economic determinants of health, so inequality and things like that. And they're all kind of really key issues that I agree that we need to think about carefully. So I'm sorry I haven't talked about them here. In terms of contracting out private providers, Anita might know more of this than I do. There's a distinction between kind of contracting out services like cleaning or catering or something like that versus kind of care that's provided. Private providers, on terms of the care, still provide a relatively small amount of care, but it is a growing share. So in the mid-2000s, they basically formalized the role of private providers in providing kind of routine operations, scans and things like that. So now about 5% of planned surgeries are going to be conducted by private hospitals or by privately owned places. But it's important to say the NHS is still paying for that, so it's not like people are facing the cost. The evidence on that actually is that it doesn't cost more money to do it that way than doing it in the hospital, because at least now they're paid the same prices for, essentially hospitals are compensated for providing a surgery, and they pay that same price to a private hospital. I don't know if you have something to say on the contracting out and things like that.
It's quite interesting, the debate about this, because how you define what is private actually turns out to be quite a can of worms. So in 1948, when the NHS was set up, GPs actually stayed as independent contractors, as they're called. So actually, most GPs are not employed by the NHS. They receive a contract, and they're in a partnership. They own their premises, they pay their staff, and then they take a profit share out of that. So GPs are officially private in all the figures, but every GP I've ever met views themselves as intrinsically NHS, and I think most patients don't see a difference. They see their GP as NHS. And there are a range of services. We were talking earlier about the way that healthcare has grown. The hospice movement, for example, which provides care to people who are terminally ill at the very end of their life. Most of that is provided not by the NHS. In fact, almost none of it is provided by the NHS. It's provided by charities, and they count in the figures as private sector. Now, so there's quite a complicated array of things. Having said that, in the mid-2000s, the government under Tony Blair opened up the system so that people who were going to have say a hip replaced or a knee replaced could choose between having that done in an NHS hospital or having it done in a private hospital. So that has grown significantly since then. One of the challenges, as George says, the NHS pays for that at the same amount of money, although obviously those providers make a profit, so there is some money there. One of the challenges at the moment around trying to shift that back is that our hospitals are absolutely chock-a-block and full, by and large, with emergency patients, and we've got long waiting lists. So I think if we wanted to reverse that, there would be some quite significant upfront costs, as we'd have to build more capacity in the NHS to take those patients back in. I think there are some really interesting questions, though, about often what we see as people's expectations of healthcare grow is it's in mental health, in hospice, in all these sort of services that the private sector, actually charities, are most involved. And the boundary of what the NHS does has often been pushed out through the involvement of things like charities developing services, and then there becoming a clamour for that to be available through the publicly funded system. Yeah.
And then, so again, getting to your question of France and Germany. So I guess there's two things in this. There's differences in the levels that people spend in the first place. So France and Germany, regardless of the systems that they have, they spend a lot more on healthcare than we do. There's also the differences. So
both privately and individuals contribute far more as well.
Yes, so in some ways we're getting at some of the issues I was talking about with moral hazard, in the sense that you would economically expect if some of that cost is reflected back on them, they would think more carefully about that care. And also in the future, they might take better care of themselves. I don't know what the empirical evidence necessarily is on that in France and Germany. But yeah, it's hard to know intrinsically how that influences people's value of it.
I mean, I'll just make this point, and I've thought this for a long time. I don't know how you feel, but basically what governments are doing, right, is they're papering over the cracks. At every election, instead of solving the fundamental problems of the NHS, they paper over cracks for a few years, hoping nothing comes up. Then something comes up, and then they're carrying on papering over cracks. And basically, I've come to the feeling, and I've spoken to some doctors, and that, like you said, there needs to be a fundamental review about how we think about it, about how we fund it, because we all have to pay more. And we all have to find a way to pay more through some form of insurance, right, that everybody pays and the poor get covered for, so it's equitable. And and realizing our health costs, because otherwise we're going to carry on. All we're going to do is just carry on papering over the cracks.
So I think it's worth saying on a couple of things in response to that. Agree absolutely that one of the problems with the I was about to say UK, but I think it's uniquely English actually, with the English system, is although the NHS is 70 years old, the way we actually manage and plan the system is like we're surprised that it's going to be there next week. And so we don't invest for the long term in the facilities that we need. We don't invest in the staff that we need. We don't modernise our services fast enough. There is a failure in our political process around that. And with social care, whilst Germany started thinking about the fact that you were having a baby boom and ageing population and put in place measures to fund and reform social care from 95 onwards, we, as George showed, we've had 20 reviews since 97 and not addressed it. Having said, so there is a problem. I think the evidence, if you look at work that people like OECD have done, though, is that more classic social insurance systems, which are what Germany and France have compared to tax-funded systems, all provide universal healthcare coverage, but in different ways. That's not the key divide, and there are pros and cons of each. So Germany, for example, the way that is funded is essentially, it's a bit like national insurance. You pay a social insurance premium for your health and social care out of your wages. Now, that has some advantages. People are aware of the cost of it. They demand quite a lot in return for that. The disadvantage of that, if you're a labour economist, is the tax wedge on unemployment. You put a lot of the cost of healthcare onto people who are employed, yeah? And you make employing an individual very, very expensive, yeah? So everything has consequences. Now, you might argue that drives some of your productivity because you invest in technology rather than rely on low wages. Sweden, for example, has a tax-funded system, yeah, but arguably has avoided some of the weaknesses of our tax-funded system. But interestingly, their decision about tax for healthcare is on a local tax. So they plan that locally and there's more accountability. And kind of one of the debates about, so there are big potential advantages from funding from general taxation. It's broad-based, all sections of society pay, you pay based on ability to pay, and you don't create these distortions between capital and labour, income and wealth, etc., which at the margin can have economic effects. The disadvantage of that is that people feel very disconnected between the payment of tax and the value they get from health and social care. And so in points in time where trust in the political process is low, yeah, one of the arguments might be that although collectively we might all actually want to pay more tax and have a decent health and social care system, that actually because we don't trust the political process to make good decisions and take our taxes and use them for the things that matter to us, we actually have an aggregate public policy failure where we can't actually raise the tax and invest in the services. And so some people say, and this kind of IFS, although ideally you'd fund this from broad-based taxation, should you hypothecate in the jargon, yeah, and create ring-fence taxes where people will say, and you might see, so I think the Lib Dems in this election, if they repeat what they said in the last election, is we'll put a penny on, I think they will say national insurance.
Well, they have already said it.
Yeah, and ring-fence that to try to overcome fundamentally the trust issue. I'm going to get more, I've got more hands up.
Everybody says everybody else can pay.
Yeah. So I'm going to get more hands up. So go 1, 2, 3, if that's okay. Yeah.
Part of the problem here is public ignorance. They don't even understand how government works, how the economy works, and yet they want to take decisions about the taxation. I mean, to take for example the death tax, 2017. Most people's wealth are in their houses, and what they do when they die, they don't need the house. But they're reluctant to give it to the state rather than distribute it amongst their children or whatever.
So my point is mainly on the unequal treatment of people that have similar needs but different medical conditions. So your point, basically. So what kind of policy can support, a better, a more equal system? And does integration of health and social care may be a possibility, a way to go forward?
So I work in the health and social care system, and we see often that social care and healthcare are so massively intertwined. It's very rare to find somebody who needs social care to not come out with their healthcare needs. So would the argument not be that increasing the funding towards social care would not eventually take a bit of a strain away from the healthcare needs?
Again, I'm going to do reverse. So we've actually done some work on what happens when you cut social care and what happens to NHS hospital use. This is obviously something that's been discussed a lot, and anecdotally a lot of people say people get stuck in hospitals because they've got nowhere to go. So we actually don't find a lot of evidence of people getting stuck there, but we find that since 2009 with these big cuts to social care that have also varied around the country, you find that in places where there's bigger cuts, you get a lot of people going to A&E departments. So a lot more, and most of these cuts originally have been to people who were kind of maybe had lower needs than the people whose care has been protected. But we end up seeing hundreds of thousands of people on A&E probably as a result of this. And interestingly enough, the biggest increase in the kind of diagnosis for those people is that nothing medically wrong with them. So a lot of these people are kind of just not coping when the social care service is being cut, and therefore they end there. So there are definitely synergies between them, and I agree that in some ways it looks odd if you kind of say I'm going to protect the NHS budget, I'm going to cut the social care budget lots, because in some ways there's going to be a reflection back of that. And that, I guess that links to how do you intertwine the health and social care system. That has been at the forefront of policy or at least what people say for several years. Whether it's really made a difference is, I guess, another question. So the idea is they're meant to pull some of these budgets together so that there's better interaction between them. But what I hear is that often people still don't communicate well. Slightly against what I said, there is, though, an increasing amount of social care that is provided by the NHS. So the NHS does have something called continuing health care, where you can essentially, if you have a medical condition and you're treated by the NHS, they will start paying for some of your social care. So that in some sense is linking the systems. But that massively varies across the country. It's not very clear exactly how you get into that system in the first place. And although that cost is rising, it's not necessarily very kind of upfront consistent policy.
And then there was a question about people's lack of understanding of
Yes.
how much it costs.
I think that's true. So there's been lots of polling that suggests that lots of people don't understand what the social care system even is in the first place. So lots of people think that you should go to your GP if you need a social care need, when really you need to approach your local authority, and even that is not necessarily the easiest thing to do, particularly since there's been cuts. So to lots of people, it's a surprise that they're meant to be paying this, and then quite rightly they're very upset when they're told that they have to pay for these things. And I think that was part of why something like the cap system is very unpopular, because people think that they should be getting this for free anyway. The other, of course, is what you were saying about housing wealth. We kind of treat most people's largest asset is their house. A lot of the time it's not actually included in the measure of assets. So if you have a spouse who lives in the house and you're in a care home, or if you live in it yourself, it's not included in that test. So some of the moves have been to trying to make it a bit more consistent, and you should include housing. But again, people get very upset about it. So,
isn't that the unrealistic nature of the system? That people say, "Oh, we want." I mean, in this country, and I've had this discussion with a number of people. People say, "Oh, we want good services," but they're not willing to pay for them. Or that they don't understand that they need.
I agree, and I think that's a fundamental. I mean, that is something that there should be a debate that we have.
Yeah, and I think it's worth saying as well on the willingness to pay collectively for healthcare, that actually, I guess it's quite difficult at the moment, because the lived experience of the last 70 years is that we've had cake and eat it apparently. So we have had a doubling of the share of our GDP that we devote to the NHS, and our tax base has not increased fundamentally. And as George says, that's largely because of compositional changes in what the rest of the government did with the Cold War dividends. So at the end of World War II, we were spending broadly 10% of GDP on defence for obvious reasons. We were in the middle of a world war. That's down now, what, at 2, well, yeah, because we're arguing about whether we now meet our NATO 2% target. And then since 2010, they tried to read per crime dividend and reduce spending on police, criminal justice, etc. The question is, have we run out of road on that compositional change? And if we have run out of road on that compositional change, how do you begin to have a conversation then with a public whose experience is that you can have an improving healthcare system? I mean, the other people who've paid are within education and students. So we shifted the balance of the cost of higher education from the state to individual students. And partly as well then, this is bound up with intergenerational fairness issues, because we're talking then also about housing assets, and there's a current generation of baby boomers who come through who have those housing assets, but will other generations have those same things? So of course, you know, health and social care, you can, there is a set of quite, you know, kind of technical questions that are really important at the start of this, but also they're bound up with these quite big, wider questions about the shape of the state, the extent, the balance between of how much we want the state, you know, to provide, to take our money and use it on our behalf versus we make those choices. And these questions also about different generations and what's the offer and what does fair look like when we look out over there. Yeah. So I'm going to do I better do one more question before we wrap up. No? Right. So, George, take-home message. One thing that people should really bear in mind. Yeah.
I'm actually going to go with what we said at the end of the talk, which is there are these fundamental challenges about how we fund all these things going forward. And it is really important to think about, you know, how much are people willing to pay, what services do we care about, should we be willing to pay more tax to look at those things, and to have a frank conversation about that, as opposed to just saying, well, we can have all of these things without how we pay for it.
Yeah. Thank you all.
One last question. What do you think will happen over the day next?
No, we've got to...
Come and chat with me
people are heading off. Thank you all very much for coming out on a very rainy day. Thank you, George.